In this final video on the thyroid gland anatomy and physiology, I'm going to kind of explore how thyroid affects different tissues, metabolism, the sympathetic nervous system, and then go through each organ system and look at the specific thyroid effects. So at the end of the last video, we looked at thyroid hormone receptor. These receptors are found in the nuclei of most of the body cells. Thyroid hormones really exert their effects in two ways. The way I've discussed before was genomically, and that is to bind to those hormonal response elements, and that triggers gene expression and protein synthesis. But thyroid can also work non-genomically. So this would be T3 within the cell can activate various enzymes and proteins like calcium ATPase, adenylate cyclase, different glucose transporters, and then mitochondrial proteins. And this can all affect basic energy metabolism. So in terms of fetal development and early development, one of the big roles of thyroid is for normal growth, normal production of growth hormone, and that is going to help promote skeletal and bone development, skeletal muscle and bone development, and then proper development of the nervous system, and especially the central nervous system. So production of synapses, growth of different dendrites and myelin formation. In the peripheral nervous system, this will help contribute to myelin and creation of healthy nerve reflexes. So thyroid is needed for growth hormone and nervous system development. Again, by about 18-20 weeks of development, the fetus is largely dependent on its own production of thyroid hormones and independent of the maternal thyroid hormones. Cretinism is the absence of thyroid hormone during fetal life, and that results in poorly developed neurons, poorly developed nervous system, can be quite severe in terms of mental retardation. There are also skeletal muscle, the improper growth. So patients with cretinism often are very short stature. They have pretty characteristic craniofacial abnormalities and so forth. Worldwide, the most common cause of this is iodine deficiency. And so this is a very correctable, preventable condition with proper iodine treatment. But it can happen theoretically if the maternal thyroid is low in the first trimester in particular. Now, there's been some studies looking at this, and we're actually finding that especially after the first trimester, the embryo and the fetus are pretty well protected from maternal hypothyroidism. That's why we kind of, in our assessments of thyroid in pregnancy, we do look by trimester, and there's slightly different needs we'll see and different levels of thyroid we're kind of shooting for. The nervous system can develop normally if iodine is given to the child at birth. So if they are born, if they had congenital or fetal hypothyroidism, and then you start giving them iodine, if it was from iodine deficiency at birth, a lot of the effects, especially on bone and skeletal muscle, can be reversed, but sometimes the effects on the central nervous system can't, and so the mental function can be compromised. So this is, again, very preventable with proper iodine supplementation. So that's in growth and fetal development. We usually think, though, of thyroid in terms of its metabolic actions. So the primary action of T3 is to increase the basal metabolic rate of nearly all your tissues. So again, we can think of it as really carrying the pulmonary respiration process of oxygen into the cells, into the mitochondria, and improving the mitochondrial activity. So here we have thyroid hormone, the gland sitting right at the opening to the lungs on the trachea, really carries the lung activity into the tissues. So it increases carbohydrate and lipid catabolism in tissues. So basically increases appetite, but also absorption of carbs from the small intestine, gut motility. It increases the production of glucose via gluconeogenesis and breakdown of glycogen, glycogenolysis in the liver, and that will increase blood glucose. It increases glucose uptake by cells and also the catabolism of the glucose in the cells, and then increases fatty acid release from adipocytes, fat cells. It decreases cholesterol levels by increasing bile secretion flow. So one of the effects of hypothyroidism is actually hypercholesterolemia. So we have to look at thyroid in some cases of hyperlipidemias to see if that's the causative factor. In fact, before our current blood tests like TSH and whatnot, physicians used to just measure cholesterol levels if they were elevated, they said, oh, you have low thyroid, and they would prescribe thyroid. We now know that many other things regulate cholesterol levels. So for example, high insulin will tell your liver to produce more cholesterol. Low thyroid would impact the bile flow. High estrogen might contribute to that as well. So there's a lot of different neuroendocrine factors that regulate cholesterol, so it's not just thyroid, but that's one of them. Thyroid in mitochondria really increases the amount and activity of mitochondria. So it increases the numbers of the mitochondria in cells, and so it stimulates what's called mitochondriogenesis, and it also increases tissue oxygen uptake and consumption. And then finally, as the energy, so remember in mitochondria, oxygen is brought in, CO2 is going to be released, and in the process, we are going to basically break down, we're going to make ATP. But in that process, some of those electrons that are going to be shuttled to make ATP are lost in, via uncoupling proteins, and that creates heat. So your major source of heat production in the body actually is in skeletal muscle from their mitochondria. The cardiac muscle also produces a great amount of heat, and that has to do with the number and activity of mitochondria. And so thyroid supports that as well. And so this is what we call the calorogenic action of thyroid, and that's going to produce heat in the body, and that's why thyroid is one of the hormones that keeps you warm. Now, just being cold or feeling cold is not a sign necessarily of hypothyroidism. There are other hormones, in particular DHEA, which also plays into this. That's probably the two biggest ones, thyroid and DHEA. But it could be other things, tissue oxygenation, things like that, which have to be looked at. So just using body temperature and what are called basal body temperatures, we now no longer recommend as a screening test for thyroid. But once hypothyroidism is diagnosed via other methods, and we confirm that a person's cold from low thyroid, we could potentially use the basal body temperatures as a way to track and follow to see if improvement is being made with whatever treatments and therapies we're giving. But DHEA from the adrenal glands and thyroid are two of the main factors that increase heat production in mitochondria. Now, another action of thyroid hormones is to really support the sympathetic nervous system in most ways. So the sympathetic or fight or flight nervous system, the thyroid hormone is going to upregulate the beta receptors. Remember, beta receptors are found on cardiac muscle, they're found in skeletal muscle, on the lungs and so forth, and they all have different roles there. But basically in the heart, the thyroid is going to support the beta 1 receptors, and so that would increase heart rate and cardiac contractility, so increase the strength of muscle contractions, and that would increase cardiac output. In the periphery, it's going to increase sweating, increase the level of bone turnover, and this is a real problem. Thyroid, especially in the excess amounts, has a catabolic effect on bone, and this is one of the reasons we're really careful about not over prescribing thyroid hormone, because it can actually lead over time to bone thinning, osteopenia, and potential osteoporosis. So excess thyroid has real effects on the bone. Of course, on the heart, it can increase the risk of cardiac arrhythmias, like triggering atrial fibrillation as well. In the muscle system, neuromuscularly, thyroid increases the hyperactivity of muscles, increases muscle contraction and reflexes. So if we had excess thyroid, we might actually see hyperreflexia. In fact, that's one of the first signs we see of any sort of thyrotoxicosis. That means excess thyroid hormones. Would be the effects on the heart and sweating, but also we might see that the reflexes are very jumpy. So looking at the patellar reflex, we of course grade that stage 1 through 4, and usually a normal reflex is a +2 reflex. Patients with hyperthyroidism will have a very jumpy reflexes, +4 reflexes. They also often would have like a fine tremor, and that's one thing I've seen in a number of patients with autoimmune thyroiditis causing Graves' disease, is they put out their hands and they have this fine tremor at rest. So those would all be sort of the actions of thyroid to upregulate the sympathetic nervous system. Remember that the sympathetics also upregulate thyroid, so those alpha receptors in the brain, when they're activated, will upregulate thyroid, so it kind of both works together. Unlike the sympathetic nervous system, though, thyroid hormones will tend to increase GI motility. Remember, sympathetics generally inhibit your GI motility. It's the parasympathetics which turn on the GI motility. So in this case, thyroid kind of works like your parasympathetics in the GI tract. The thyroid also tends to cause vasodilation and tends to lower blood pressure to a degree. But for hypertension, we are always checking thyroid levels to see that a person is not hyperthyroid, because it can, in excess, really create hyperthyroidism. Generally, on the cardiovascular system, and again, this is just like I talked about with iodine, that hormesis curve. We can say there's a hormesis curve with thyroid. So we do need, on all of our tissues, an optimal level. And the problems are when we start going too far to the right in the concentrations endogenously of the hormone. But on the cardiovascular side, generally T3 has positive inotropic effects. So that's going to affect the contractility of the heart muscle and make it contract more efficiently. And chronotropic, meaning time effects, is going to increase heart rate. So increases heart rate and cardiac output. It's going to increase the transcription in the sarcoplasmic reticulum of calcium ATPase, and that's going to affect the amount of calcium that like a heart muscle cell can store, and that is going to increase the rate of the diastolic relaxation. So it's going to affect the cardiac action potential, what it's called, and it's going to affect, we'll look at that in the cardiovascular section, how the heart muscle contracts. It's going to increase the expression of myosin, so that's going to enhance the systolic function on contractility. It's going to increase the expression of the alpha adrenergic receptors, increase the rates of depolarization and repolarization of the SA node, so that's going to increase the heart rate. And then it's going to decrease peripheral vascular resistance, diastolic function, and ventricular filling. So it's basically going to keep more blood in the periphery and sort of take the load off the heart. So we'll see that in heart failure, interestingly, and hypothyroidism, that's one of the potential outcomes, is heart failure. And I've had a number of patients in early heart failure, stage 2 maybe, of the New York classification. They're getting some symptoms on exertion, things like that. As soon as we corrected their thyroid, all the symptoms of their heart failure actually reversed. T3 also produces production of erythropoietin. That is, remember, a hormone produced by the kidneys, which increases the production of red cells in the bone marrow. It also allows oxygen to dissociate from the hemoglobin more easily in the tissues, in the peripheral tissues, so increases oxygenation. So it really supports the blood, the hemoglobin function. Again, I put this under cardiovascular because we're always looking at cholesterol as a atherosclerotic cardiovascular disease, a risk factor. But the thyroid actions will increase cholesterol synthesis and degradation. So it's going to increase the level of amount of bile that's made and excretion, so that'll get rid of cholesterol. But also the thyroid hormones increase the number of LDL receptors, which will take LDL out of circulation. So in hypothyroidism, we often see either true hypothyroidism, or we'll talk about this later, subclinical. Subclinical means your TSH levels are rising. They're above the normal ranges, so that's indicating primary hypothyroidism, but your free T4, free T3 levels are still normal. And we call that subclinical, versus overt, you're going to have high TSH with low free T4, low T3, free T3. So we're going to see decreased left ventricular diastolic function in hypothyroidism, subtle systolic dysfunction, and then increased risk of atherosclerosis and coronary heart disease and MI. So these would both, the diastolic and systolic dysfunction would contribute to heart failure. In hyperthyroidism, again, either overtly or subclinically, we're going to have increased heart rate, potential for increased arrhythmias, atrial fibrillation. That's another really big thing we have to look out for any thyroid hormone replacement therapy, is not to over-medicate to prevent that. Increased mass of the left ventricle over time, so left ventricular hypertrophy. Impaired ventricular relaxation, so that can result in diastolic dysfunction and heart failure. decreased exercise performance, and then increased risk of cardiovascular mortality. So both hyper and hypothyroidism are associated with worse cardiovascular outcomes. So again, we want to shoot for the middle of the curve to prevent that. Patients with acute and chronic cardiovascular disorders often have altered peripheral thyroid hormone metabolism, and that can further alter their cardiac function. So really protective roles on the heart in the normal ranges for thyroid. So it's important to consider. The remainder of the thyroid effects here are pretty straightforward. So on the lungs, T3 maintains normal respiratory function. It is important for fetal lung development. We might expect that based on just the fact that thyroid seems to assist the whole pulmonary function. There are also glucocorticoids, again, cortisol and DHEA, which are very important for lung development. And so both thyroid and DHEA are often hormones I'm looking at in patients with chronic pulmonary diseases like chronic bronchitis, emphysema, but especially idiopathic pulmonary fibrosis. Those would be things to consider. The thyroid actually inhibits lung fibrosis by improving the mitochondrial function in the lung epithelium. And the respiratory muscles are also regulated by thyroid. So in hypothyroidism, I'll just jump to that first, we usually see more significant effects on the respiratory system. So increased shortness of breath, fatigue with exercise, decreased respiratory drive, increased sleep apnea, increased skeletal muscle myopathy, as well as pleural effusion potentially, and worsening of asthma, all with hypothyroidism. So that's always something to consider with asthmatic patients, or again, and of your chronic pulmonary patients, what's their thyroid doing? Hyperthyroidism, we see more of a increased respiratory drive, dyspnea on exertion, and real weakness of the respiratory muscles and breathlessness. So I've seen this in patients with early hyperthyroidism. They have no exercise tolerance. They just do like walk up a hill and they're completely out of breath. Their muscles feel weak. They feel really shaky. It's like they have this adrenaline rush going on, but that might be one of the manifestations. In terms of GI effects, the thyroid hormones really define the basal metabolism of the intestines. So thyroid hormone receptors are found throughout the gut lining, specifically in the myenteric plexus. Remember, that's part of the autonomic or the enteric nervous system that regulates peristalsis. So in hypothyroidism, we're going to see decreased peristalsis motility, more constipation. We see in the esophagus more almost like achalasia, but decreased peristalsis, dysphagia, worsening, or even the beginning of hiatal hernia. You know, hiatal hernias are not just a structural problem. There's two types of hiatal hernias, basically. One is the true periesophageal hernia that often comes about from trauma to the abdomen and so forth. That's where the fundus of the stomach protrudes into the mediastinum, into the chest cavity. That needs a surgical correction to really pull that down. But in terms of the classic sliding hernia that a lot of people talk about in functional medicine, that actually is often a motility disorder. And that we need to look at the vagus nerve, but also look at the thyroid hormone to see if that might be contributing to it. In the stomach, hypothyroidism will decrease peristalsis, decrease acid production, and that might increase dyspepsia, bloating. In the small intestine, we're going to see decreased motility and increased overgrowth of bacteria, SIBO. So a lot of people are talking about SIBO as a cause of IBS, all these things. I would look at it more as a consequence of a dysregulated gut terrain, in particular a neuroendocrine dysregulation, in this case thyroid. So having low thyroid, we're going to see SIBO as a consequence, not as a cause. So just treating SIBO in the way that it's treated with the different regimens of antimicrobials and the different diets is not addressing the problem. The problem in some patients might actually be the low thyroid. In large intestine, we're going to see constipation, but you can have diarrhea from bowel overgrowth or just the osmotic effect of poorly digested foods. I didn't put the pancreas in here, but we typically with hypothyroidism see decreased pancreatic exocrine output, and we're going to get poor digestion from that. In autoimmune thyroiditis, in the Hashimoto's, we're going to see an increased association with other autoimmune diseases like celiac, primary biliary cirrhosis, and pernicious anemia. So we're often going to screen for those in those patients we end up diagnosing with Hashimoto's because they are commonly correlated. In hyperthyroidism, we'll see increased peristalsis, motility, sometimes dysphagia, but often dyspepsia, epigastric pain, increased nausea, vomiting, increased appetite, diarrhea, and more steatorrhea and fat malabsorption. So these would all be the classic findings in hyper and hypothyroidism. Again, hypo, we're going to have usually more dramatic symptoms with that. Now, in terms of the liver, the thyroid actually plays a significant role, which tells you a little bit about the way the body is put together. We have the organ functions, but what actually talks to the organs and tells them to either up or down regulate their activities will be the neuroendocrine system, the autonomic system with the endocrine system. That's really what regulates the whole homeostasis. So I often look at the organs as kind of secondary to the neuroendocrine regulation. In terms of liver, thyroid upregulates pretty much everything. So the type 1 deiodinase is found in the liver. It converts to T4 to T3 like we talked about. It also clears reverse T3. That's the one that's inactive. Some sources say up to 30, even 40% of the plasma levels of T3 actually come from liver conversion. It's the final site of thyroid hormone metabolism via the conjugation as well. We talked about glucuronidation and sulfation in the last videos about how the body rids thyroid in addition to reverse T3. So in hypothyroidism, we often see decreased hepatic metabolism, detoxification. We're going to see increased potential liver enzymes in up to 50% of our patients with hypothyroidism, decreased gluconeogenesis and BUN, decreased bile production and flow, and as a result of that, we don't clear a lot of our other hormones or cholesterol adequately, and as a result of that, we might see increased gallstones, and then decreased LDL receptor expression. Again, that would affect cholesterol clearance, so we're going to see a buildup of cholesterol, of LDL, and then increased non-alcoholic fatty liver disease. Huge epidemic of that now, and thyroid is one of the hormones which helps to regulate that. The hyperthyroidism, we're going to see the opposite. Again, increased liver enzymes potentially, increased liver activity, but decreased liver blood flow. We're going to see mild increases of alkaline phosphatase up to 64%, and that could be due to bone turnover. So if you have a patient on thyroid medication, they show an increase in alk phos, that's a sign, hey, you're starting to see some bone loss. It could also mean many other things, so that's very nonspecific. We have to look, of course, consider any potential cancer, things like that. But if we've ruled all that out, that might be a sign of increased bone turnover. In untreated hyperthyroidism, we see more of an incidence of cirrhosis and then increased bile production and flow. You know, going back to this over here, this should actually be hypothyroidism. I'm sorry, I misspoke. This should be decreased ALT, AST. So on the lower side of your liver enzymes in up to half your patients because of lowered liver activity. Okay, so that is hepatobiliary actions. On the renal urogenital system, the thyroid hormones support kidney development and their physiology, so it increases renal blood flow. It increases the GFR, the filtration rate, increases the protein synthesis and growth in the kidneys. In congenital hypothyroidism, we often see congenital renal anomalies. It's interesting, again, to think of, well, I've mentioned the thyroid-lung connection, but we can also make a thyroid-kidney connection in that, you know, the thyroid itself is bilobed, just like the kidneys, bilobed. Interestingly, embryologically, the kidneys actually begin up in the neck region, then they migrate down. The kidneys, of course, put out the EPO, which increases hemoglobin, and the hemoglobin is what takes the oxygen from the lungs into the tissues, and then it's thyroid, which then helps to utilize that oxygen. So they all work together in these really elaborate different physiologic networks. But it's interesting that in congenital hypothyroidism, we often see congenital renal anomalies. It also increases the activity of renal transport proteins, so like the sodium hydrogen ion exchanger, and that can affect the amount of sodium in the blood and so forth. So in hypothyroidism, we usually see decreased GFR. Now, interestingly, in chronic kidney disease, usually stage 3, 4, and 5, we see a low T3 syndrome. So that's basically where the T3 gets low, and that will be going to worsen metabolic functions. That will, of course, be associated with an increased primary hypothyroidism and subclinical hypothyroidism. And some suggest there are actually some benefits. So it's actually sparing the kidneys, protecting them. If you increase the kidney metabolism, that could, depending on what the source of the chronic kidney disease is, that might accelerate the damage to the kidneys. So this could be a protective mechanism. So the question is, would you give thyroid in these cases? That might actually worsen the chronic kidney disease. So I just put a little bit of a caveat about thyroid hormone supplementation in those patients. In hyperthyroidism, we see an increased GFR and increased activation of the renin, angiotensin, aldosterone system, and that could potentially then increase blood pressure. So although thyroid has a vasodilatory effect on the vasculature, which usually decreases blood pressure, here through the activation of renin angiotensin, we might see an increase of blood pressure in hyperthyroidism. And so that's, when we work up hyperthyroidism, about 5% of those cases, remember, are what we call secondary hyperthyroidism. And a good percentage of those cases are endocrine, like having high cortisol, but in this case it would be hyperthyroidism that might contribute to it. Lastly, we'll look at the effects of thyroid on the skin, bone, and muscle. Thyroid hormone thyroid receptors are expressed throughout the skin, and we often see other effects. Thyroid interacts with other hormones, so for example, decreased thyroid hormone will actually decrease luteinizing hormone from the pituitary, and that will result in decreased androgens, which would have further effects on the skin. So they kind of work together. But one of the classic findings we see with generalized hypothyroidism is myxedema. And that's a skin condition caused by increased glycoaminoglycan deposition. These are very water-hungry glycoproteins which will sop up water like a sponge, creating spongy edematous tissue. And this creates a non-pitting edema. So we see people's faces are often very puffy around the eyes or the neck. In hypothyroidism, that's myxedema. In the case of hypothyroidism, in the epidermis, the skin often becomes coarse and thin and scaly. We see the non-pitting edema in the dermis from the myxedema, and also the hands, the face, the eyelids. The inability, as I mentioned before, we need thyroid hormone to basically cleave beta-carotene into vitamin A, and vitamin A is of course needed by your skin epithelium to reproduce and grow. So it's a very important vitamin for the skin. So we can actually get a vitamin A deficiency in hypothyroidism, and that's what would lead to all of the skin changes we see here in the epidermis. But you would also see the inability to convert your dietary carotenes into vitamin A, so they build up in the skin and you start looking yellow and orange. So orange, yellow skin could be a sign of carotenemia, which would be from the inability to break down the beta-carotenes from the diet. Could also be just a normal thing. If you eat tons of carrots and things like that, your body just can't keep up with that conversion, and so you start to build some up in the body. Hair tends to become dry and brittle, coarse. You might have alopecia, and then the loss of the lateral 1/3 of the eyebrows can occur from low thyroid. The nails become not coarse, but coarse, dull and thin nails. Increased risk of potentially fungal infections, tinea on the nails. And then sweat glands become dry. We get xerosis, decreased sweating, and then we get decreased sebum as well, the sebaceous glands, with hypothyroidism. Hyper, we get more of a smooth, thin skin. Fine hair, it kind of loses the wave in the hair, so if you have wavy hair, it becomes more straight. Again, alopecia, more shiny, friable, soft nails. These are called plumber's nails. That's typical of thyroid toxicosis or hyperthyroidism. Again, remember, thyroid toxicosis means an excess of thyroid hormone. It can be from any cause. So hyperthyroidism, it could be from taking too much thyroid hormone, etc. That would be thyroid toxicosis. In terms of bone, both high and low thyroid can lead to bone demineralization. So I've already mentioned hyper, and we have the real problems with bone there. So we see premature accretion of the growth plates, so that could cause a shortening of stature. In adults, we'd see a increased bone turnover, decreased mineralization, activation of the osteoclasts, and then hypercalcemia, hypercalciuria, so more calcium is going to be lost in the urine. And then in subclinical hyperthyroidism, we also see increased bone loss, especially after age 65. So again, if we're supplementing thyroid in patients, we have to be really careful about overdoing it because it could create that. In hypothyroidism, we're going to see growth retardation, decrease of the endochondral ossification, decreased stature, and then decreased bone metabolism, decreased bone formation, decreased bone resorption, decreased calciuria and alk phos, and we might see increases parathyroid hormone now. And as a result of this, you get bone that is not being properly recycled, and we're going to have an increased risk of bone fractures. So I think the important take home here is we usually think of hyperthyroidism causing bone issues, but hypo can as well. And so both kind of go together. Finally, on skeletal muscle, this is a major target of thyroid hormones. Both D2 and D3 are found in skeletal muscles together with the thyroid hormone receptors. Basically, thyroid hormone is going to increase the rate of skeletal muscle contraction, increase the rate of muscle relaxation, increase ATP production and mitochondrial density, as well as increasing muscle repair. So in let's look at hypothyroidism first. We get more paresthesias and arthralgias, more muscle cramping like leg cramps at night, and then increased myopathy. Some people even think some of the ligamentous disorders like Dupuytren's contracture, whatnot, might all be related to low thyroid in some patients. Hyperthyroidism generally causes muscle weakness. We of course get increased bone turnover, we get increased muscle turnover, hyperreflexia, that fine distal hand tremor. So I've seen in hyperthyroid patients, again, they have very little exercise tolerance. Their respiratory muscles become weak, they get short of breath very easily, and they just can't really sustain any sustained aerobic or anaerobic effort. So that would be the hyperthyroidism effects. So I just wanted to go through each of these different organs and tissues to kind of show how profound thyroid hormone is for maintaining your overall metabolism. So we're always clinically, again, if we're trying to back up and look at what is the system that regulates all of your homeostasis, it's the neuroendocrine system. Thyroid is part of that, and so we want to look out for thyroid disorders in patients with any of these kinds of conditions. So that summarizes it for thyroid anatomy and physiology. In the upcoming videos, we'll look at different thyroid pathologies, hypothyroidism, hyperthyroidism, thyroid nodules, and then thyroid cancers.